Okay, so in the interest of time, we are going to go ahead and get started. Good afternoon, everyone. My name is Maisha Lumpkin, and I'm the education coordinator here at Gillis Club South Florida. This evening, we are gathered here today for a frankly speaking about cancer, specifically gynecologic cancers. Next slide, please.
It takes a while to transition.
And we have the lovely Jacques from Memorial Healthcare, who will be speaking about this topic for us this evening. Next slide.
So I have no financial disclosures to report, thankfully. It's coming. There we go.
Okay, so the mission of Gillis Club and Cancer Support Community is we are a relentless ally for anyone who is striving to manage the realities of this disruptive disease. No one can or should face cancer alone. While we have witnessed many advances in treating cancer, nothing takes the place of power, inspiration, companionship, and connection that comes from community, because community is stronger than cancer. And so this slide just highlights the agenda of today's workshop. So it speaks really to three pillars of the foundation of Gillis Club. So it's to empower through knowledge, strengthen through action or by action, and for our members to be sustained by community. And so Jessica will go in more detail about those aspects. And because we are a part of Cancer Support Community, these slides were medically reviewed and updated by Dr. Alexi Wright in September 2022. And so a little bit about Gillis Club South Florida. So we were founded on the philosophy that when cancer happens, it happens to the whole family and their surrounding community. Therefore, the clubhouse and programs are available for women, men, children, and teens living with cancer and their family and friends. Gillis Club believes that those affected with cancer are the experts, and by providing activities and networking opportunities, our members feel empowered in their decision-making and finding new ways to live with cancer. And so we do open our doors to anyone who is impacted by cancer. I will put in the chat our contact information. If you aren't a member already, feel free to either send us an email, give us a phone call, or stop by the clubhouse to initiate that process. And without further ado, we're going to have Jacques go ahead and present this information to us.
Perfect. Thank you so much for that wonderful introduction. And I'm so happy to be partnering with Gillis Club yet again to just really empower all of our patients through knowledge. So today we're going to discuss some things, such as terminology, overview, a very widespread overview of gynecologic cancers, staging, understanding treatment options, and common side effects of treatment. During the presentation, I'm just going to turn off the video of myself because my brain sometimes is looking at multiple different aspects of the screen. So I want to make sure that I'm completely focused. But this is very informal, so feel free to jump in at any time. We have a small group, and I love the small group settings because you can be more relaxed. You can ask any questions you may have. I'm here to answer them. And then I'll also have a time at the end to answer any additional questions you may have during the presentation. So thank you all for really taking the time out to join us today on a pretty beautiful Tuesday afternoon, especially compared to the recent weather we've been having here. Okay, now, so some terms that we're going to be discussing today include gynecologic oncologist. So gynecologic oncology is a field of medicine that focuses on treatment for cancers of the female reproductive system. This includes ovaries, the vagina, uterus, the cervix, and the vulva. A gynecological oncologist is a doctor that specializes in treating these types of cancers. Genetic testing refers to tests that use blood or saliva to look at the DNA of the patient. And that is really helpful for a lot of physicians and APPs, which stands for Advanced Practice Providers. So those are your nurse practitioners and your PAs. So basically the entire provider group that allow them to look at any type of mutation. So mutation is a change in your genes that may possibly increase your risk for ovarian or other types of cancers. And biomarker tumor testing is a test that looks at a tumor cells to see if there are specific mutations that treatments can target. So I know that nowadays we've heard of things like immunotherapies or targeted therapies. And so these are certain medications that instead of kind of targeting the entire cancer cell, it will look for certain cells that may carry a specific marker on it and just attack those. And those medications usually have a smaller side effect profile, which means they're easily tolerated or easier tolerated by patients. Now, any type of cancer that starts in the reproductive organ system of someone assigned female at birth is considered a gynecologic cancer. There are 5 main types of gynecologic cancers, including ovarian, cervical, uterine, vaginal, and vulvar. The 6th type of cancer, which is called a fallopian tube cancer, is very rare. So what are some risk factors that we look at in regards to these cancers? So age, first and foremost. Risk increases as you get older. I know we've heard that time and time again, and that's pretty universal across all different types of cancers, and we see that specific to gynecologic or GYN cancers as well. The second could be ethnicity. There seems to be some higher risk among people in North America, Northern Europe, and Ashkenazi Jewish people. Also having a history of endometriosis, or not having a child until age 35, not being able to have a child, or never having a child, having a family history of ovarian cancer, and having a family history of colon, uterine, GI, or urogenital cancers as well. Now, again, these are just risk factors only. This does not mean that if you may fall into any of these categories that you will end up with any type of GYN cancer, but there is some type of correlation that we've seen when we look back, at all patients. And of course, everybody's risk factor is different and will have a different percentage. Now, ovarian cancer is a type of cancer that starts in the ovaries. The ovaries, as you see here, let's see if I can annotate right here. The ovaries are a part of the reproductive system. The reproductive system usually has 2 ovaries, one on each side of the uterus. Each ovary is about the size of a walnut, and it has 3 parts. One part is the epithelium that covers the surface of the ovary, and you can kind of see it. This is a very good graphic here. The second is the germ cell. So that's what actually produces the egg that is released each month. And that egg then travels through the fallopian tube to get to the uterus, where it can be fertilized and possibly result in pregnancy. Then you have sex cord stromal cells, which produce sex hormones such as estrogen. If a cancer starts to grow in the epithelial cells of the ovaries, it is called epithelial ovarian cancer. Most cases of ovarian cancer start in these cells. Another part of the body near the ovaries is the fallopian tube. So we talked about how rare that cancer is if it does evolve to cancer. And ovarian cancer is a very broad term that sometimes includes epithelial ovarian, fallopian tube, and peritoneal cancers. All 3 of these cancers are really thought about and treated in the same way. Now, quick check-in. A lot of times I ask, have you heard of cancer staging, or why is cancer staging necessary? What diagnostic tests like blood work or imaging did you perform, or have you heard of your family or friends having performed to understand their stage of cancer? And does a stage of cancer impact treatment options? Okay, so we're going to jump into some of those. Back to fallopian tube cancers. Again, as I said, they're very rare cancers. But now that we know that, some of the ovarian cancers may start in the fallopian tube, again, like I said, is really treated in the same way as ovarian cancer is. So we're going to move to a different part now. So we talked about fallopian tube. We talked about the, fallopian tube right here, 2 fallopian tubes. We talked about ovarian. Now I want to talk about cervical cancer. So your cervix, and it, from the names that I see, it appears we have women on the line. So sometimes you think of the cervix, it becomes familiar to you when we think about childbirth and when a woman is in active labor. And, to see when they say the term, how far along is she in labor, or is she at the point where she needs to start pushing to deliver, what they're usually looking for is the cervical canal part to see, has it thinned out, okay? So that cervix is in between the vaginal canal and the actual uterus. So cervical cancer forms in the tissue of the woman's cervix, which is the lower part of the uterus that connects to the vagina. And it's usually a very slow growing cancer that may not cause symptoms. Infection with HPV, also known as the human papillomavirus, is one of the main causes of cervical cancer. About 95% of cervical cancers are caused by this virus, which is why now there's actually an HPV vaccine for younger people to be able to take in their very early teenage years. They start getting it actually at about around the age of, I would say 11 or 12. Both boys and girls get this vaccine because boys can have the HPV virus and transmit it, or should I say young men or men have the HPV virus and can transmit it to women, and then the women have it, which can lead to cervical cancer. That's why the vaccine is given to both boys and girls. The vaccine is meant to prevent this, which is why it's ideally given before the potential start of them being sexually active, okay? The good news is most cervical cancers can be detected early with preventative screenings. And screenings are so important for cervical cancer just because they often do not cause any symptoms until they're much further along in the development. So if you go for your preventative screenings with your GYN, that's where you can potentially catch any concerns that may be happening early on. HPV infection and other risk factors may act together to increase the risk, and about half of all cervical cancers occur in women between the ages of 35 and 55. So we often see this in younger women. So it's very important for women ages 21 to 65 to have regular preventive screenings in the form of pap smears or pap tests, okay? Now, when we move up a little bit and talk about the uterus, uterine cancer forms in the tissue that lines the inside of the uterus, okay? Endometrial cancer is a type of uterine cancer and is one of the most common cancers in American women. Most endometrial cancers start in the cells that make the mucus and other fluids of the uterus. And uterine cancer can also start in the cells that make up the wall of the uterus. And oftentimes we hear things about fibroids, and people with fibroids may have a procedure called like a myomectomy. So so that's the muscle, because as we know, the uterus is just really a strong muscle. Again, when we talk about childbirth, the uterus is what carries the baby, but that's also that muscle that helps push the baby out and through the vaginal canal for birth, okay? But when a lot of people, sometimes you hear the word uterine cancer or endometrial cancer used interchangeably, that's fine because they're mostly treated in the same way. Now we'll move to a cancer that's not as common, and that is vaginal cancer. Most vaginal cancers are also caused by the HPV virus, and when found in early stages, it can often be cured. Now, there are two main types of vaginal cancers. There's what we call squamous cell carcinoma, and there is adenocarcinomas, okay? So, cancer that forms from squamous cells, so that's really the thin lining that lines the vagina. It spreads very slowly and usually stays near the vagina, but may spread to other parts of the body. This is the most common type of vaginal cancer and is found most often in women ages 60 or older. Adenocarcinoma begins more in the glandular cells and is more likely to spread to other parts of the body and is most likely found in women ages 30 or younger. I will tell you in practice, this is not something that I see very often. In practice, we're mostly seeing and treating cervical and ovarian and endometrial/uterine cancers. Now, vulvar cancer most impacts the labia majora. So this is the labia. So these are the folds or the opening. And this is usually the part of the body that we can see ourselves, right? So if you go to use the bathroom, when you wipe, things like that, you'll be able to see this area. This is also a very rare cancer. It accounts for less than 1% of all cancers in all women. It is very slow growing, and the most common type is a squamous cell type of vulvar cancer, okay? Again, I've probably only treated a handful of these in the past decade, but it is something that if you notice, some type of growth or abnormality down in that area, it's going to be very, very important that you contact your GYN to get it checked out. Now, let's talk about some signs and some symptoms that may appear with some gynecologic cancers, okay? You can see physical changes for some of the cancers that we just talked about, like vaginal or vulvar cancers, right? So you can have a lump in the vagina, constant itching, changes in the color or the way the vulva looks, maybe a sore in that area, or skin changes. But a lot of the other symptoms are not physical. They're just the way you feel. So you can have fatigue, you can have bloating, trouble eating or feeling full quickly. A lot of times, women will just have very generic abdominal pain, but this is pain that is more chronic and is constant. Every now and then we could have abdominal pain from a myriad of things. It could be constipation, it could be diarrhea, we could have ate something wrong. But if you or your loved one, your friend is complaining about just this chronic, ongoing, frequent type of abdominal discomfort or pain, I always encourage them to contact their doctor to really further evaluate that, okay? Sometimes, you would have frequent urination or changes in the bowel movement. One of the biggest one is abnormal bleeding. So especially for our postmenopausal women, they should not have any type of vaginal bleeding. If you even have one episode and it's been more than 1 or 2 years, you know for sure you're past the perimenopausal stage, that you're postmenopausal and you have vaginal bleeding, you need to call your PCP or go see your GYN right away for further evaluation on that. Pelvic pain or pain during sex is really not normal. And so that is something that, you would need to look further into as well. And then we talked about the physical changes. And then always, if you have any burning or itching or pain in that area that is not going away, then definitely go see a healthcare provider about that. Now, we talked about, we gave a general overview of some of the GYN cancers, actually all of the GYN cancers. We talked about what some of the symptoms might look like. Now we're going to pivot a little bit to treatment options, okay? And the good news is there's lots to choose from. Treatment will depend on the size and the staging of the cancer. Now, most of the staging for these cancers, which we call solid tumor cancers or solid organ cancers, are, staged on the typical 1 through 4 stage that you may have heard of with other cancers like breast cancer or lung cancer, things like that. And obviously, not obviously, but when you hear of a lower number, so it's stage 1 or stage 2, that means that the cancer is either local or locally advanced and caught pretty early. And usually when you catch a cancer in a very early stage, you have more treatment options, such as surgical intervention, having a surgery. If there's a small little area that's affected, the surgeon can go in and scoop it out. Maybe even radiation. Radiation is a very targeted therapy. And is usually indicated when, caught in an earlier stage. And then, you always have chemotherapies, immunotherapies, and clinical trials as well, okay? Some of the things that is very appropriate is when you have a treatment provider, your oncologist who's talking to you about, cancers, it's important that they take a very holistic approach, okay? Because like I said, for some cancers, like the cervical cancers, we see the incidence in very young women, in their 30s, who may still hope to get pregnant or have children. So if that's the case, they need to speak with their doctor about their options before they start treatment, because it may also affect the overall treatment plan, okay? And again, depending on the type of cancer, you can have, let's say, surgery. Surgery is one of the main treatment options for some cancers, especially ovarian. And what happens is the surgeon will go in and will remove as much of the cancer as possible, which is often called debulking. Or sometimes they'll be a little bit more aggressive and they say, hey, since we're in there, maybe we need to consider a total hysterectomy, where instead of just getting the ovaries or the fallopian tube, maybe they take the uterus as well, in order to reduce any potential chance that a cancer cell has spread and lodged somewhere else, or, that down the line, a recurrence, may happen, meaning the cancer may come back. Another option is chemotherapy, which uses drugs, so medications, to destroy any cancer cells. Now, sometimes, chemotherapy is given with the intention to cure somebody, meaning that by the time they're finished with the medicines, over 3 or 6 or 9 months or whatever it is, that there is no evidence of any cancer remaining in the body anywhere. However, sometimes chemotherapy is given what we call in a palliative manner, meaning they can't say that they will cure the cancer, but they want to shrink the cancer down and reduce the burden of the disease on the patients, okay? Chemotherapy can be given different ways, such as intravenously through an IV. It can be given orally by a pill, or sometimes even an injection like a shot, so there's different types of chemotherapies that can be given different ways. Now, targeted therapy use specialized drug that targets specific changes or those mutations that we talked about very early on in the presentation. I'll give you an example. So there is something called, that's a lung cancer, but there's something called like a HER2 mutation. So there's a medicine called Herceptin that's used in breast cancer. And that medicine just targets any cell with that HER2 protein in it, okay? You can also have radiation therapy, and then immunotherapy works with your body's immune system to find and attack cancer. So one of the most popular immunotherapies that we use right now is something called Keytruda or pembrolizumab. And it first started years ago to treat lung cancer. Keytruda even has like generic commercials, on the television about it. And it's been so successful that they've tried it in other tumors with other cancers. And now we use pembrolizumab across the board. We use it for lung cancer. We use it for GYN cancers. We use it for colon cancers. We use it for breast cancers. And pembrolizumab specifically targets something called the PD-L1 protein. And this is a medicine that's through the IV, and it's given either once every 3 weeks or 4 weeks. And it just literally targets those cells. So what I like to tell my patients is imagine these therapies being like the military, right? So the military has the Army, it has the Navy, it has the Air Force, has SEAL Team 6. Well, the Army is kind of generic. I always equate, chemotherapy to being similar to the Army. They're usually the first ones in, and they just kind of go in and do what they have to do, but you can have a lot of collateral damage, right, from the Army. Whereas targeted therapies and immunotherapies to me are like SEAL Team 6. They go in and they target their specific, person that they have to target. And sometimes everybody else around them doesn't even know they're there. They just go in, do what they have to do, bam, they're done and they're out. And so that's how I kind of give a visual representation, so to speak, of the different types of therapies. Now, there's always the option for clinical trials, and I love this. Clinical trials are research studies that compare the most effective known treatment for a specific type or stage of cancer with a new approach. This can be a new medicine that's just tried for the first time, or it can be established medications that are just tried in different combinations, but just to see what ends up with better, what we call patient outcomes. Okay, so there's different types of clinical trials. There's phase 1, phase 2, phase 3, phase 4, things like that. So different organizations, like my organization, we offer various clinical trials in various phases. We have, phase 1 clinical trials, phase 2, where maybe these medications are being used for the first time in humans, in women. And so they've been successful when they've studied them in the lab, and now they want to try them in humans. All the way to stage 3, where maybe we know it already works, but we want to try, this particular regimen against a standard of care to see which is better. And I will tell you, a lot of times clinical trials can seem scary. There are some clinical trials that don't involve medicines at all. They are literally just asking you permission to be able to follow you year after year after year, to see, hey, 5 years from now, are you still doing well? 10 years from now, are you still doing well? Clinical trials are the only way we can come up with new treatments. And so that's why I always encourage them, because if we don't try, we'll never know if they work. And I'll tell you that things like chemotherapy, 70 years ago was not a thing. When chemotherapy was first introduced through the National Institute of Health, a lot of those oncologists were shunned by the medical community, because back then it was really surgery and even radiation therapy that were the big dogs, so to speak, in cancer care. Back then, if you had breast cancer, your only treatment was surgery, chop it off, as they say. But we know that that's not often the best course of treatment for some women, and in some situations it is, and in other situations it's not. And so luckily, we were able to continue to make progress in chemotherapies, and chemotherapies really came to fruition with what we call the liquid tumors. So those are leukemias and lymphomas, where they were first found to be successful. And then once they had a lot of success in those liquid tumors, then we transitioned them over to the solid tumors. And now, fast forward 70 years, and they're one of the mainstays, of cancer treatment. But again, clinical trials are always something that I encourage. There are different types of clinical trials. And so it's something that I always encourage my patients to even consider based upon what is best for them at that particular time. So, one of the things that these presentations look to do is also to strengthen and empower you guys by action. So we're going to discuss how to do certain things like prepare for appointments, think about second opinions, and again, touch base on clinical trials. So when we're talking about preparing for appointments, the goal and concerns you have for your treatment or your loved one's treatment should be the forefront of the appointment. It's important that you're able to receive the benefits of each appointment as they pertain to your or your family member's specific and unique cancer journey. This is very important that, clinicians and caregivers in the room really try to work together to have the best outcomes. And it's your appointment. So you feel free to ask about side effects, to ask about, what should the expectation be moving forward, to ask about any symptoms or concerns you have, or the latest information on clinical trials, because new clinical trials are always coming up. Something that may not have been available in January can be available in June. Always ask about information, maybe in a different language, in a language that you may feel more comfortable with. Maybe English is not your primary language. Or, if you want something in a different language, we have plenty of tools and resources. And when I say we, I don't mean just Memorial Cancer Institute, but all of our organizations now can get you any information you need in pretty much any language. Also, now that COVID is kind of moving past, take someone with you to appointments. I know sometimes even me, when I go to my own doctor's appointments, I get in my car and I be like, well, wait, what did the doctor say again? Or what medicine am I supposed to be taking? Because I'm there and I'm present, but sometimes there's a lot of things going on. I have a lot of things on my mind and I may forget, oh yeah, he told me to start taking it in 2 days, not 3 days, something like that. Always, bring a pen and piece of paper and write things down, take notes. Or nowadays, we have a lot of electronic resources. So for instance, with Memorial, we have something called My Chart. So if you forget what the doctor said, you at the tip of your finger, you can go in your own chart and you can look at the medical notes. We also have something called an after visit summary. So before you leave the office, there's a printout that says everything that you need to know regarding your next appointment and things like that, okay? Ask them if they have any supportive staff like social workers or financial navigators or healthcare navigators to also help you navigate in this journey. If you have any questions about your medicine, a lot of times they have pharmacists on site, in the organization, not just in the pharmacy, but in the actual clinic that can come over and help you, or sometimes in the infusion centers that can talk to you about any questions you may have about any of the medicines that you're prescribed. And then if for some reason you don't feel like your healthcare team is addressing your concerns, you can always, always, always get a second opinion. Please don't feel that your provider is going to be upset with you or is going to look down on you or anything like that. It happens all the time. Especially living in South Florida, we have access to multiple different cancer centers, just, 15, 20, 30 minutes away. And so sometimes going to get a second opinion, even if you maintain your care with that first provider, but sometimes going to get a second opinion. And if they say the same thing, that's going to make you feel even better about your journey and the treatment plan that was provided for you. Okay. So again, this is your journey and you have to feel comfortable with your healthcare team. Now, the cancer support community has specific tools that you can utilize on their website. You can print out even a checklist that you can take with you to any appointments to kind of keep you on track. They also have articles that you can read and just some prompts that help you, with maybe, thinking about some question that you may want to ask, because sometimes there may be things that you didn't even think to ask. And then again, once you get home, you're like, oh man, I was just there. I should have asked them, okay? So at the end of this, I'm sure that you'll be provided with a website. If not, I'll make sure I get it for you. But again, there are tools online and specifically through the cancer support community and Gilda's Club that can help you with your healthcare planning. Again, it is important to talk to your care team about your goals and values. This will help you develop a trusting relationship. Your goals may change over time, so you want to make sure that you and your provider are on the same page if that happens. You want to check in often with your care team to make sure your treatment decisions are working towards your goals. And it's okay if those goals change, 100%, because that's life, right? Life changes. And so something that you may have talked about last year or wanted last year may look different this year, and that's completely fine. It's what you need to focus on, what is most important for you. Things that the healthcare provider may not think of, like, can you continue working? Should you work full-time? Should you work part-time? Should you explore retirement or disability? And so asking them, what should I expect, is very important. Also, are there any community resources? I know Gilda's Club does a fabulous job at really pairing and being that liaison to other community resources that are out there that may help you in your specific needs. This is just a video. It's unfortunately the link is not working, but it's just something saying that, remember, you can always seek a second opinion or change doctors at any point during your treatment if your situation changes or if you feel you need a different level of care. And again, these are just more articles regarding clinical trials and really assessing if clinical trials are right for you, okay? Everyone facing a cancer diagnosis of any kind should be aware of clinical trials as a treatment option, even though not everyone can be or should be on a trial, but it's just good to know that those are out there. So we're going to discuss some topics like caregiver concerns and life after diagnosis. What we see, kind of across the board is that once you've kind of started on this journey, life may look a little different for you. And so universally, one of the things I've seen in patients, and I've worked with both pediatric and adults, is that you feel like there's a loss of control, right? Because you or your loved one was diagnosed with this, and how could this have happened? And now you have to go out and ask others for help, but there's really nothing you can do, or so you think there's nothing you can do. But I promise you there is a way to take back that control regardless of the diagnosis, okay? Some other people experience some unwanted aloneness. They feel isolated, or they may feel like, hey, this is happening to me and none of my other friends have experienced this, so they don't really know, how it might feel. And so sometimes patients tend to isolate themselves. Something else that I see is that sometimes they want to keep it a secret because they feel like the diagnosis may burden their loved ones or their friends, and they don't want to add that extra stress to their loved ones' lives. But I promise you, again, I've been doing this for over a decade, and I really encourage my patients to be open and honest about their feelings, not only to themselves, but to their loved ones. It's not a burden. I see on the flip side that a lot of the loved ones, when they find out, especially later on, they're upset because they're saying, if I would have known sooner, I could have done this, or I should have done that, or I could have helped him through this. And instead of the loved ones feeling burdened, they actually want to know in real time, okay? And then always the stress of living with uncertainty. A lot of times healthcare providers will say, we will try to do this, or, we hope that we have this outcome. But obviously there's nothing guaranteed in medicine. There's nothing guaranteed in life, period. But not having that guarantee can be very stressful. You may want to put the experience behind you once you've completed treatment and have life return to normal the way it used to be. Some people just want to have a fresh start at something new, but it is okay to understand that, sometimes even after the diagnosis or after your treatment, there may be side effects that you have to consider managing, okay? It's important to know that it can take time to recover. Many people feel uncertain about how they'll move forward. They feel anxious about the future. They feel anxious about, what will happen if the cancer comes back and recurs? And so there's always this balance of feeling hopeful, yet cautious. Some of my patients saying, we're cautiously optimistic. One of the hardest things after treatment is not knowing what's next. And so the first few months, after treatment can be a time of, a little bit of confusion for people. And again, that's why it's very important to have that emotional connection with your family and friends and be honest and open with them, so that they can help you through this. One of the things that a lot of the cancer centers now offer is something called survivorship care. And in survivorship care, they give you something called a survivorship care plan. So that is usually a document that lists your journey. And in that document, it has your specific diagnosis. It will usually list the doctors that have treated you on your treatment team, whether it's a surgeon or a medical oncologist or a radiation oncologist. It will also state the actual treatment that you had. So if you had radiation, it may say you received 3,000 grays in 12 fractions, to the uterus or something like that. If you've had chemotherapy, it'll tell you exactly the chemo you got. Okay, you got Avastin and gemcitabine or Taxol, something like that. This is really important to have because not only is it important for your other healthcare providers to have access to, like your primary care physician, but just for you to have, so if something happens, you can look back and say, oh yeah, I got this medicine, or oh yeah, I forgot I had radiation from this date to this date. Because for some medicines and for some people, they may have to follow up with a cardiologist or a certain specialist because of the treatment that they've had previously. Or you may have a different doctor. You may have had a PCP for 5 years who then moved away or retired. Now you have a new doctor coming in. So you want to make sure that all your healthcare providers are on the same page with your treatments. In addition to that, it's important not just to focus on the physical aspect, but also your emotional wellness. So a lot of the cancer centers also provide psychological care and supportive care. So at Memorial Cancer Institute, for instance, we have 3 trained psychologists who all they do is work with patients who either are currently undergoing treatment or previously underwent treatments. Okay, so they focus on patients who have an oncology diagnosis. And I think that's very important. Also, what's important is when you're going through this, it's very important to know which side effects are just short-term and which potential side effects can be longer-term or long-lasting. There are some potential side effects that are short-term, such as hair loss or nausea and vomiting, but others may be a little bit longer-lasting, like neuropathy. There are some treatments where neuropathy can only, you really only experience it while you're on that treatment, and some where neuropathy can potentially be lifelong. And if that's the case, then there's certain treatments that they may offer, things that may be non-medicinal, such as acupuncture. Most people don't realize that acupuncture is a wonderful, wonderful intervention and really helps with things like nerve pain, which is neuropathy. Other things that are very important to talk about that a lot of times patients don't feel comfortable, but I encourage them to discuss are things like intimacy. When is it okay to be intimate with your partner? What safety precautions should you put in place when being intimate? And sometimes just getting the okay to be intimate is very important, because a lot of times I'll have patients come to me and say, I haven't been intimate with my partner in 6 months, even though I'm finished with chemo, because I didn't know if it was safe. And I would say, oh my gosh, I'm so sorry. I should have brought this up. Or, I wish you were more comfortable with asking me, because you are completely clear to be as intimate as you want, 5 months ago, you know what I mean? So please don't be shy. As healthcare providers, this is what they do. This is what they've dedicated their lives to do. They're not shy about talking about it. You don't have to be shy about talking about it. Everybody, their goal and your goal is for you to live your best life. So after your treatment has finished, you may continue to see certain specialists to manage any potential late or long-term effects. Or sometimes they may, refer you to other subspecialists as well. For instance, I mentioned before, there's one medicine that's actually a targeted medicine, the one that's like Herceptin, which targets the HER2 protein. And it's a great, great, great medicine. But for some people, about 1 to 3% of patients, they can have cardiotoxic effects. What does that mean? That means it can affect their heart. And so for those patients that we see it's affected their heart, they may need to go see a cardiologist, after their treatment for 3 months or 6 months or a year or something like that. Again, we talked about neuropathy. Most neuropathy is very limited, self-limited, and goes away after treatment. But there are some patients that it can continue. And neuropathy is similar to what diabetics get, the nerve pain, the numbness and tingling to the hands or the feet. And so if that's the case, sometimes, again, we need to refer them out to specialists who can help them manage those side effects. And then cognitive changes. Sometimes we see that, there's a term out there you may have heard of called chemo brain. Chemo brain, for the most part, again, seems to be self-limited, while you're on active treatment. But for some patients, and usually for more pediatric patients, we will continue to monitor their cognition for a long time afterwards, just to make sure they're meeting their developmental milestones. But even for adults, as we get older, do we see any issues that maybe we need to have you go see a neurologist or something about? But again, these are things that this is part of that holistic approach that I spoke to earlier about, the physician not just focusing on the cancer itself, but your whole entire well-being. And one of the biggest things that we always promote is physical therapy. At Memorial Cancer Institute, we actually have a program called the Cancer Recovery Program, where you get, I think it's 3 months of free gym membership to work out at one of our fitness centers after you've completed treatment. This by far is one of the best treatments that you can do for yourself across the board. Even, it trumps medications, the whole nine. It's physical therapy. There was a study one time on how to combat chemotherapy related fatigue. So fatigue is actually one of the top side effects that is reported by patients across the board. It crosses all cancer types, all treatments, the whole nine. The number one side effect across the board is fatigue. So they did a research study and they looked up, okay, how can we improve fatigue? They tried medications, they tried stimulants, they tried vitamins, they tried different diets. And do you know what the number one thing that improved fatigue was? It was actually physical activity. So the patients who literally every day did 20 to 40 minutes of very moderate, mild to moderate. We're not talking about running 5Ks, no marathons, no, what is it, cycle bar or soul cycle, none of that. But literally just walking around your block, a brisk walk for 20 to 30 minutes a day had a humongous impact and improvement in patients' overall well-being and specifically fatigue. So, I am the biggest proponent for physical therapy there is. There is even something called the Cancer Experience Registry. And that's something where, again, that's, I talked to you about some clinical trials that all they do is just ask people questions and follow them for years and years and years afterward, just to check up and see how they're doing. And so that's something similar to this. And with the CER, I found that 42% of cancer patients were concerned about moving around, walking, climbing, lifting. These are what we call activities of daily living, and they're very important to be able to do so that you can maintain just a regular, normal lifestyle. And so no matter if you've gotten radiation therapy or surgery or chemotherapy, I always still advocate for physical therapy because it could be indicated. There's something else. Sometimes you might hear the term exercise therapy as well. Again, when I say exercise, that term is used very loosely. It does not mean anything intense, but literally just moving, just the act of physical movement for a sustained period of time, getting your heart rate elevated for a sustained period of time does absolute wonders. I do see the time. I'm going to do a time check. So I'm going to move a little bit faster on these so we can get through these slides. And you just let me know when my time is up, but I'm going to keep on going. Okay. All right. So again, talking about overall physical wellness, eating and nutrition is extremely important. I put this neck and neck with physical activity. And so eating a well-balanced diet, I am not a fan of absolutes. So I'm not somebody that's going to say you absolutely cannot have sugar. You absolutely cannot have alcohol. You absolutely cannot do this or that. I don't, to me, everything in moderation. And we want you to have a joyful life as well. But it's very important to know that fruits and vegetables and eating what they call lean and fresh things are extremely, extremely important. Now, one of the other things that people sometimes, after they get through the real intense part of therapy is, thinking about changes that they may have to their just body based upon surgery or effects of chemo or radiation. And this is real and it's completely normal and it's completely fine. Chemotherapy can cause hair loss or weight change. Radiation can cause changes to your skin. Surgeries can leave scars on the body. And how do you cope with that? It's okay to mourn. It's okay to feel sad or angry or frustrated, but what's not okay is being stuck in those places. Okay, so we have to know how, once we feel those emotions, how do we process those, cope with them, and then continue to move forward and look at ways that we can really learn to love our new appearance. Okay. So those things, are also very important. And that's some of the things that some of our psychologists, that's some things that we learn just from support groups. When we talk about and have these conversations with other survivors, oh, they had this experience, maybe I can try that too, or just knowing that you're not alone and feeling that way. Okay. And then again, we talked about sexuality and intimacy. That definitely the medications, surgeries, radiation, all of those can impact that. Please, please, please have those conversations with your healthcare provider because everybody's journey is different. And so you're going to be unique and you need to know what is okay and, where do you need help with? And it's okay to have those conversations with your healthcare provider. In regards to fertility, especially when we're talking about our younger women, cancer treatments can definitely affect their ability to have children. And so it's super, super important for us on really early on in those visits to talk about what their plans are for family planning. Because for women, we can do things such as egg freezing and egg banking and, things like that, but it takes time. So there are instances where we have time that we can do egg retrieval and store the eggs while we do the treatment planning. But there are other times that unfortunately we've caught the cancer too late in the game, or it's very aggressive and we don't have 6 to 8 weeks to wait to do the egg retrieval, and unfortunately we have to proceed with treatment. But again, having those conversations very early on is very important because they're time sensitive conversations. And then just going through and talking about feelings, and it's okay to have those feelings of anxiety, of depression, but also where do we get advice and coping mechanisms from to help process those feelings and continue to move forward. So the cancer support community actually has a program called My Lifeline, and it's used to connect those affected by cancer during and after treatment, as well as helping caregivers and friends and families to be able to reduce stress, anxiety, and isolation. Okay. So, there's definitely support and resources and tools out there, and we'll make sure you get that information. Now, one of the biggest issues with cancer care that not a lot of people talk about is just the financial toxicity or the financial aspects. Okay. So according to the CER, 44% of patients had health insurance or money worries during treatment. And I feel like I see that more and more, unfortunately, as time goes on, especially with the insurance companies, unfortunately causing, us to jump through more hoops in order to get approval or higher copays. A lot of the cancer centers have financial support as well. So for instance, we have a pharmacist dedicated to helping patients who have high copays. And basically we go straight to the pharmaceutical company and say, hey, our patient needs this medication, but they have a $2,000 a month copay. We need help, please help us. And a lot of times the pharmaceutical companies will come through with copay assistance. You'd be surprised at some of the grants and programs and assistance that we receive. So never feel hopeless. Just continue to reach out to see how you can move to that next step to get what you need for your care. Okay. Now, unfortunately, what happens if the cancer recurs or progresses? The good news is usually there's always additional treatment options and there's always hope. And I'll give you guys a perfect example. You know, about 7 years ago now, back in 2015, prior to 2015, there were only really about 2 or 3 treatment options for multiple myeloma. Multiple myeloma is considered a blood cancer. It's one of the most common blood cancers. And the treatment options were very, very limited for patients. Literally in the year of 2015, 3 new treatments for multiple myeloma came out and completely changed the game. Multiple myeloma went from a cancer that was just horrible, for lack of better words, to something that now is so highly treatable to the point where I now consider it what we call a chronic disease. We may not be able to cure it, but you can live with it for 10, 15, 20 years, and you can live a good life with it, with all the newly diagnosed medications. So, it's always fearful, and there's something called scanxiety. You see right here, scanxiety, where, scan to scan people, the level of anxiousness just skyrockets through the roof. But, you never know what the future holds. And so again, if you would have asked me in 2014 of multiple myeloma, I would have never in a million years, we would be where we're at in 2023, where we're curing myeloma at this point. I put cure in quotations, but we're almost there. But even if we're not curing it, the quality of life has improved tremendously. Okay, so to me, hope is the cornerstone of everything. And then, there's always the opportunity. Some people may be on maintenance therapy. So even though they can't stop therapy, they may need to get a medication once a month or something like that. But again, they're still able to continue living and have a good quality of life with that. I'm going to skip through this really quick because we kind of talked about post-treatment survivorship care plans already. And again, that it gives you a summary of your treatment. It will tell you any additional screenings you need, or if you need to be referred to any specialist. So for instance, a woman who may have breast cancer may continue to need mammograms or, some type of breast imaging moving forward. Sometimes it's every 6 months for a year or 2 years, and then it goes to every year for 3 years, something like that. I do want to touch base really quick on palliative care, because sometimes people get palliative care confused with hospice, okay? And those are 2 totally separate things. So when you're talking about hospice means that a person is transitioning from aggressive treatment to just comfort measures only. Hospice does not mean that we push somebody in a room, we lock the door, and we say, oh, well, they had a chance, they had their chance. That is not hospice. Hospice just means that instead of treating the cancer aggressively, meaning lots of chemotherapy, they may feel weak, they may feel sick, they have lots of doctor's appointments, things like that. And we're just transitioning to saying, you know what? We want to focus on the quality of life versus the quantity. And so we're just going to focus on your comfort, what we consider comfort measures only. We care for you. We're going to make sure you feel well every day. We're going to give you whatever you need, whether it's oxygen or pain medications or a special bed or, whatever you need in order to focus on just your comfort while you live out the rest of your life. Okay. Whereas palliative care really just focuses on relief of symptoms, even if you are on active treatment and aggressive treatment. And how can we help you live your best life and improve your quality of life right now? Meaning, do you need something for pain? Do you feel better when you're on oxygen? Maybe do you get constipated a lot from the treatment? So let's make sure you have a good bowel regimen. Do you need to, change your diet? Things like that. Whatever you need, they focus on helping you provide relief from those symptoms. And then lastly, we really need to focus on caregivers as well. Sometimes caregivers get lost in the shuffle. You know, all the attention is on obviously the person that's dealing with the issue, which is rightfully so. But you know, caregivers are just as important in the team, I should say. So cancer affects not only those with the disease, but also the people who care for them. And being a caregiver for a person with cancer can be stressful. At times they can feel angry or guilty or alone or afraid. So if you are caring for someone with cancer, it's just as important that you may seek out support groups as well, or look for extra help. Sometimes you can't do it all by yourself. Ask family, ask friends, ask members of the community. There are some programs that have what we call respite care. So if you're a caregiver and you're like, you know what, I just need to get away for a day or two, they can provide somebody to come into your house to really help you, you know, with some of your tasks, okay? And what a lot of people don't realize is that caregivers provide emotional support more than anything else. And that can be kind of, you know, draining a little bit. So how do we fill their cup back up? How do we support their caregivers who are caring for our patients? It's very important that, you know, they feel involved and that they're helping with the decision making. They often help manage the finances and coordinate medical care. So they do a lot. And it's important that they take care of themselves so they can also take care of the patient. We want to make sure they're not burnt out. They need to know how to pace themselves. They need to know how to set certain limits, but also be flexible, but at the same time being realistic, okay? The cancer support community really gives a lot of resources for them, how to prevent burnout, a lot of recommendations. And so, you know, it's just know that the resources are out there for them. It's just a matter of finding them and tapping into them. And that's where organizations like Gilda's Club and like the cancer support community come in, because they can really, really help, again, be a liaison for that coordination of care, okay? And then talking about our network partners, you know, here's the information. We'll make sure that you guys get this information so that you can access any of the resources that we talked about earlier today, or additional resources that we may not have been able to tap into. This information is available in multiple languages, which I love. And they also have care coordinators that can help you, and just a lot of online resources that are available to access, you know, at your fingertips. It's important that we all continue to be an advocate, you know, for people impacted by cancer. I know that I fight the fight, not only at work, you know, with insurance companies, but even outside of work. We're very, very involved with a lot of nonprofit organizations. This is not even my legislature, you know, this is apolitical. This doesn't matter if, you know, what you believe in, what you don't, who you voted for, across the board. You know, we need to continue to advocate for cancer care, making sure that, you know, our policymakers are educated on these issues and how they may affect people with cancer, because policy changes really have a downstream effect, and they affect everyone, not only the patients, but the healthcare providers and what we can and cannot do. You know, cancer affects nearly 17 million people across the country. So advocacy can lead to increased high quality and affordable medical care. Also, you know, social programs that can help just across the board. And not only that, preventative programs as well, because prevention is key. We want to make sure that we can access, you know, preventative screenings like pap smears, like mammograms, like ultrasounds, like colonoscopies. All of those things are extremely important. All right, I am so out of time, but if there are any questions or concerns, I am more than happy to answer them for anybody. Thank you so much for taking the time to listen. I enjoyed this. Hour went by so fast and I enjoyed all of it. And I can go on and on for days.
Thank you, Jessica, for the amazing presentation on gynecologic cancers. So we are able to take some questions about today's workshop, or any questions that you have for Jessica or myself. I am going to put in the chat our contact information and how to get involved in Gilda's Club. I do want to, so Jessica mentioned a lot about our programs that we offer. And so our programs are offered through support groups or individual counseling by some of our social workers on staff. We also have educational programs like this afternoon. We have various healthy living and healthy lifestyle classes, social and networking events, but a big component of our program at Gilda's Club is also resources and referrals in our care coordination program. And if you have any questions, feel free to either ask Jessica directly by unmuting yourself, or you can put it in the chat or direct message me.
Hi, I have a quick question. I don't know, I'm in my car. I don't see access to my chat. My name is Pascal August, and it was a wonderful presentation. Thank you so much. I have a question when it comes to mostly minority women. I think they have a very hard time getting doctors maybe to